Welcome, everyone. It's the top of the hour, so we'll get started. I'm Dia Waguespack in Houston, and I'd like to welcome you to our talk today, which is Sparsentan in key FSGS patient subgroups, analyses from the DUPLEX trial. Our speaker today is Dr. Chris Gisler. He's the Senior Medical Director of Travere Therapeutics. And joining him for our discussion will be our panelist, Dr. Gerald Appel, Professor of Clinical Medicine at Columbia University, Irving Medical Center, and NewYork-Presbyterian Hospital, and Dr. Howard Trachtman, board-certified pediatric nephrologist and adjunct professor of pediatrics at the University of Michigan. I think none of our speakers or guests needs introduction today, and we look forward to the talk and a welcome discussion afterwards. So with that, I'm going to stop sharing, and I'll turn it over to you, Dr. Gisler.
All right. So yeah, hey, thanks so much, Dia, for the introduction. We're really excited today to talk about Sparsentan in the FSGS population. So basically, they already introduced everybody, but really excited to have Howard and Jerry here. And I'm going to kind of go to them a little bit early in the discussion because I think everybody's really excited to kind of hear their perspective. So certainly be bringing them in frequently to get some commentary as we talk about some of the data. We'll highlight Sparsentan as the first approved medication for FSGS. Then really take a step back and look at some of the pathophysiology of FSGS, sort of look at what we've been doing and kind of paths forward to what we can do to now better treat these patients. Then we'll spend some time looking at the DUPLEX data and also dive deep into the genetic DUPLEX data, which I think is also really interesting, and then kind of follow up with the discussion, as Dia mentioned. So starting off, really excited, in April, we received notification from the FDA that Sparsentan was approved for management of FSGS. So now you'll recall we have two indications, both in FSGS and IgA nephropathy. So in FSGS, Sparsentan is indicated to reduce proteinuria in adults and pediatric patients ages 8 and older with FSGS without nephrotic syndrome. The caveat there, so the definition of nephrotic syndrome is the presence of all three of these factors concomitantly. And that's proteinuria greater than 3.5 grams in 24 hours for adults, or greater than 2 grams per gram in pediatric patients, a serum albumin level less than 3, and edema. So all three factors have to be present to be considered nephrotic syndrome. This would distinguish it from something like a history of nephrotic syndrome or nephrotic range proteinuria. Both of those types of patients would be eligible for Sparsentan, provided that they did not have active nephrotic syndrome. And then the other indication, obviously, is our indication in IgA nephropathy, which we're really not going to touch on much today, but obviously it's indicated to slow kidney function decline in adults with primary IgAN at risk for disease progression. Sparsentan does still have a REMS and a box warning. Now, the REMS was reduced from monthly to quarterly. Some endothelin receptor antagonists, predominantly Bosentan, did have an issue with liver toxicity. Now, because Sparsentan in its clinical trials throughout IgAN and FSGS showed no evidence of drug-induced liver injury, also in our real-world experience, we've not seen that. The REMS was reduced to quarterly, but should still be checked. And also, there's obviously a box warning for embryo-fetal toxicity. Both endothelin antagonism and RAS antagonism can be harmful to a developing fetus. So women of childbearing potential should actively avoid pregnancy. And certainly now that we have the pediatric indication, once a female approaches reproductive age, there needs to be effective counseling there for our pediatric nephrologists. Really getting into the crux of the science today, we want to start just by translating kind of some biological insights into effective treatment strategies for FSGS. And start just by centering in on FSGS. So although it's a rare condition, still a leading cause of kidney failure. And so we know U.S. prevalence about 212.6 per million in adults, and about 50,000 patients living with progressive kidney disease due to FSGS. We know that this is a tough disease because it disproportionately affects African-American patients 2 to 3 times more likely. And we know that these patients, when they're diagnosed, tend to come to us late and also still tend to progress to end-stage kidney disease, despite, our best efforts. And so here, obviously, I think you all are very excited to hear from our panelists. But Dr. Appel, when you think about FSGS in clinical practice, what makes the disease so challenging for patients and for nephrologists to actually treat them to kind of slow the progression of their disease?
Right. So one of the most challenging things is that this is a disease, FSGS, that is defined by the histology, but that's not what we see clinically. We know there are many different etiologies of FSGS, and even though they may look the same or similar, that these different etiologies have different pathogenesis and they also have different treatments. Trying to get this out to people that we've trained for years or said, this is FSGS, this is FSGS, that it's very different if you have somebody with a genetic disease, somebody who has primary disease, or somebody who has secondary. So I think that's one of our big challenges, and getting them to hone in on individualization of therapy.
Yeah, no, I think that's really helpful as we think about the different types, and we're going to dive into that a little bit more as we go. I wanted to center kind of FSGS again around proteinuria. So just like we do with IgA nephropathy, where we think of proteinuria as kind of a key hallmark of how well are we doing with controlling the disease, we need to think about it that way with FSGS as well. And so these are the UK national radar data that reinforce proteinuria as a key indicator for FSGS outcomes. We all know, the UK radar data for IgAN really got nephrologists thinking differently about being more aggressive with proteinuria reduction in IgAN and knowing that IgAN was not a benign disease. So here in FSGS, we learned basically similar in pieces of information that FSGS, is again, you predict how you're going to do based on your level of proteinuria. So this was a cohort that was enrolled back starting in 2010, adult and pediatric patients. It was a large cohort. So the N was 1,303 patients with a median follow-up of 7 years. And they had to have biopsy-proven FSGS. And their first UPCR with the onset of disease was defined as when the UPCR was greater than 1.5 or their earliest biopsy. All forms of secondary nephrotic syndrome were excluded here. And what RADAR did is, just like it did in IgAN, is it established that relationship in proteinuria and outcome. And so here's some of the data from the picture paper from Jason back in 2025. And we see different ranges of proteinuria. So ranging from basically complete remission, which is that top blue line, all the way to nephrotic range proteinuria greater than 3.5 grams per gram. And again, just like we learned with IgAN, achieving a lower proteinuria threshold, especially achieving complete remission, is predictive of better long-term kidney survival, as we follow these patients out. And here they're following the patients out to 10 years. And you can see you have an over 80% kidney survival in our patients that get to complete remission, where the story is very much the opposite. If they're not getting to remission, you see that people with the nephrotic range proteinuria that persists, really kidney survival around 20% at 10 years. So again, this story of proteinuria, certainly we're going to have to individualize treatment and think about how we treat these patients. But at the center, we need to ground it with proteinuria management should be a focus. Now, Parasol looked at basically the same question, but from a slightly different lens. And so Parasol was an international collaborative effort to really look at what are appropriate endpoints in clinical trials for FSGS. And they obviously wanted to look at proteinuria, eGFR as these surrogate endpoints, and they integrated data from multiple different registries, observational studies, and clinical trials to basically come up with a way that we can do a better job with designing trials and predicting outcomes so we can actually get drugs for FSGS. And this was led by Laura Mariani in Michigan, but many worked on this. And you can see Neptune, CureGN, among others, were involved in contributing to this. And it was a partnership between academic nephrologists, the FDA, and patient advocacy groups. And their end, again, because they brought so many people together, quite large, 1,626 patients with FSGS that they followed. And they learned a few things from this. First, they learned that while eGFR is a rational endpoint for a clinical trial, it may not be feasible because of the variability of the eGFR slope during the clinical trial. It makes it tough, and you would need very large numbers, somewhere in the range of 500 to 900 per group, in order to get a trial to show a 1 ml per minute per year difference in GFR. So what they did find and they demonstrated is that proteinuria is obviously biologically plausible, but also a feasible endpoint. So here's just one of the main endpoints that they chose, and that was the less than 0.7 grams per gram. And so what they show is that after that 2-year run-in, like they would be in a clinical trial, if you did achieve that less than 0.7 grams per gram, how did you do? So the people that achieved there were on the blue line, and you see an over 80% kidney survival in that group. If you did not achieve that less than 0.7 grams per gram, you're on that green line, and obviously only about a 60% survival at 84 months. Now, because the UK radar data did not add their data to this, the UK radar data registry was used as the validation cohort. And that's the data that I'm showing you on the right-hand side. And you can see that these two curves look remarkably similar. And so RADAR was able to validate the great work that Parasol did. Now, Dr. Trachtman, you were involved very much in the Parasol project. I think Parasol and RADAR both strengthen the link between proteinuria and outcomes. But how do you explain this to clinicians and patient advocacy groups when we're trying to shift that mindset of everything has to be about eGFR to let's think about proteinuria when we're looking at trials and looking at outcomes?
Great question, Chris. I think what we've accomplished with Parasol is FSGS is a complicated disease, the way Jerry has outlined at the very beginning. We now, even KDIGO is willing to acknowledge that there are at least 4 subgroups, and there's probably more. And because historically clinical trial activity in the area of FSGS was really like a graveyard, because trials were very, very difficult to document success. I think we now understand that this is not a problem with the drugs, not a problem with the investigators, it's not a problem with the sites, but rather the biological variability of the disease. And in the context of a feasible clinical trial, GFR is a brutal endpoint to achieve. And what Parasol has done is it's refocused our thinking to say that proteinuria reduction achieved within the context of a clinical trial that's acceptable to patients about 2 years in a randomized double-blind arrangement. A reduction in proteinuria subsequently over long term is associated with a reproducible and meaningful preservation in GFR. So what I would want to emphasize is we know at the end of the day that what's meaningful to patients is preservation of GFR. Nobody wants to be put on dialysis. Nobody wants to lose their kidney function. But accomplishing a documentation of success for an intervention in the context of a 2-year clinical trial for FSGS is just infeasible. And what Parasol has done is to say that proteinuria is in the biological pathway of the disease, and achieving a meaningful reduction is associated with a subsequent preservation in GFR, and therefore it satisfies both ends, or speaking to patients that they don't have to be on trials of in really unacceptable duration, and defining an endpoint that's reproducible.
So I think this is cool because Parasol may open the door for us to have lots of new therapies in IgA nephropathy, in FSGS, sort of like we have in IgA nephropathy here in the next 5 to 10 years, and really be able to improve that, precision medicine in treating these patients. Dr. Appel, from your perspective in the clinic, has the learnings of RADAR and Parasol changed anything that you've been doing?
I think they definitely have. What Howard said is absolutely true, that you need a surrogate marker here. You can't wait 10 years. And, it's just each glomerular disease is a little bit different. That's been shown for many years now, that in terms of how fast they progress. So, we're fortunate in IgA nephropathy that they've accepted proteinuria as the marker very quickly. Here, this is going to swing the entire balance over to saying, look, getting that proteinuria down does make a difference. It just takes longer than we've been doing the studies for. So I think it's very, very important. And I think getting the message out, and the fact that, Parasol, which is made of, great components. We are in CureGN, we were in Neptune. Columbia was in about 3 or 4 of those studies. They're very well done studies, and showing that they say the same thing that RADAR says is very important.
And we were talking with Dr. Gale, a couple of days ago, and he was kind of talking about, this relationship between eGFR and proteinuria. And he had a really good analogy, whereas the eGFR slope is sort of like an airplane's altitude. And so it going down, the slope may or may not be predictive of what's going to happen. But he said the proteinuria, especially when it's elevated, is sort of like the engine being on fire of the plane. So much more of a concerning signal there that those patients are headed for problems. And I think both of these data sets, clearly show that. Now, we have an opportunity to intervene there, and we know there are going to be many pathways that we focus on, in FSGS. But one pathway that we know plays a role that we're able to currently clinically manage, and we're going to go through that data with Sparsentan in a bit, is the role of endothelin in FSGS. And I think a lot of us in training really did not learn much about the role of endothelin. I feel like we knew very much about angiotensin and the RAS blockade, kind of pathway, but endothelin relatively new. Now, we know that both of them have historically been viewed through a hemodynamic lens. We know that angiotensin affects predominantly the efferent arteriole, right? We also know that endothelin is one of the most potent vasoconstrictors in the kidney. And so a lot of their benefits were thought to be hemodynamic initially. And while that's true, we now know that there's actually a lot more. Endothelin and angiotensin play a role in inflammatory cell recruitment to the kidney, in mesangial cell proliferation. Again, that's of particular importance in IgA nephropathy, and also in podocyte injury. So we know that endothelin causes podocyte effacement, podocyte detachment, and ultimately podocyte apoptosis. And so all of these lead to progressive glomerular injury, resulting in progressive kidney disease. Now, Jerry mentioned earlier, we think about many different types of FSGS, and really FSGS is just the pathologic diagnosis that we see on slides, but we need to really start dialing back and thinking about, well, what are the different causes? And I think ideally with precision medicine, we're going to be really able to target these in the next 5 to 10 years. But what's important to know is that regardless of whether you have a primary, so an autoimmune type FSGS, a genetic-based FSGS, undetermined cause, which hopefully will eventually go away, or a secondary cause, it all results from podocyte injury. So while the podocyte's being injured in different ways, podocyte injury, death, and loss is what causes the progression that we see in FSGS. And we know that these are mediated by endothelin and angiotensin. Clearly other mechanisms at play, but endothelin and angiotensin certainly play a role. So when we think about these patients, regardless of what that podocyte injury or stress is, highlighted in that purple box, they all lead to upregulation of endothelin and angiotensin. Now, ET1 acts on the ETA receptor, and Ang2 acts on the AT1 receptor. These are both on the podocyte, and these cause progressive podocyte injury. They also mutually upregulate themselves. So angiotensin upregulates endothelin, endothelin upregulates angiotensin. And that's why I think when we think back, we've used RAS blockade for decades and decades without success. We've not been able to get these patients to complete remission of proteinuria, and we've also seen these patients progress. So blocking both pathways represents a strategy to potentially preserve that glomerular filtration membrane, prevent the podocyte detachment and cell apoptosis that occurs when both of these pathways are upregulated. And if we can do that, we can obviously reduce their proteinuria, which we know also feeds back to upregulate them further. And we can prevent further podocyte depletion and hopefully prevent progressive kidney disease, which is kind of shown here on this graph. And sparsentan is, the way that we can consider that. So sparsentan protects the podocyte by simultaneously blocking both endothelin and angiotensin. So it's a novel, non-immunosuppressive, dual endothelin-angiotensin receptor antagonist, or a DIARA. And so by blocking both of these pathways, it's been shown to be podocyte protective, obviously reduce proteinuria, and reduce fibrosis. Now, we've shown that in clinical trials and also in some preclinical data. So here's just sort of a sampling of some of the preclinical data. And what's interesting is in each of these different mouse models in the preclinical setting, the results were very much the same. So our first model was a TRPC6 mouse model, basically a transgenic mouse with podocyte-specific overexpression of TRPC6 to mimic FSGS. And so again, there we show that in that model, sparsentan was able to reduce proteinuria, protect the podocytes, and also limit fibrosis. What was interesting about the TRPC6 model is that it compared itself not just to a placebo, but also to losartan. And sparsentan was shown to be superior to losartan even in that model. We had two other models that show basically the same results. So the adriamycin rat model, which was a toxin-induced rat model that mimics FSGS, shows the same data. Again, that podocyte protection and the reduction of proteinuria. And then finally, we have an anti-nephrin antibody rat model that showed, again, reducing proteinuria or using sparsentan, reduce proteinuria and protect podocytes. This model more mimics that serum factor-induced nephrotic syndrome, so sort of mimics FSGS, minimal change disease, caused by anti-nephrin antibodies. We also showed in that study that sparsentan did protect the glomerular endothelial glycocalyx. So we're going to step back and move forward then to go through looking at some of our DUPLEX data as well. But before I move on, I wanted to step back for a second and ask Dr. Trachtman. So we've typically viewed endothelin and angiotensin, as regulators of glomerular hemodynamics. Today, with some of the data I've shown here, just very briefly, a lot of that's changed. So how's that changing the way that you're thinking about treating FSGS?
A great question, Chris. I think what we're learning is we as nephrologists need to get smarter and smarter, and to cubbyhole drugs and say they act in one specific mechanism is probably doing them a disservice. And I love the podocyte. It's an amazing cell, and it's pivotal to the pathogenesis of virtually all of the primary glomerular diseases. But what I think we're learning from the sparsentan experience is that any intervention that can act on the endothelial cell, the mesangium, the podocyte in some aggregate way will improve the outcome, the stability of the kidney, preservation of the podocyte, which is a terminally differentiated cell that can't be replaced, prevent endothelial injury. And what I think this is doing is it's broadening our thinking about drugs that could be potentially useful. So of course it's wonderful to have a drug that's very targeted, and I think the paradigm for that will be the glomerular causes of FSGS, and clever people like Mo and Salim are doing wonderful work and potentially designing gene replacement therapies. But for the other forms of disease, it may take a bundling of drugs that target the different contributing steps in the damage to the glomerulus that lead to podocyte injury and then culminating in FSGS. And I think the sparsentan experience is teaching us that the broader we think, the better we will do in terms of identifying effective therapies.
Thanks, Howard. Now I want to move on and now just kind of the DUPLEX that you started to allude to. So we're going to show the importance of proteinuria reduction and some of the findings from our DUPLEX phase 3 clinical trial. So again, just as a reminder, DUPLEX was our phase 3 clinical trial in FSGS comparing sparsentan to max label irbesartan. And so this was not a placebo-controlled trial. So our comparator arm, just like it was in the PROTECT study in IgA nephropathy, was irbesartan that was protocol titrated to a maximum dose. Now, to be in this study, you had to be 8 to 75 years of age. And so one important caveat is that we did include the pediatric patients, although we won't be showing that data today. We'll ask Dr. Trachtman to comment on that a bit later here. The patients had to have biopsy-proven FSGS or a documented genetic mutation. And we did attempt to include secondary causes. To be enrolled, you had to have a UPCR greater than 1.5 grams per gram and an EGFR greater than or equal to 30. And now there was a 2-week washout period, and then patients were started on sparsentan, 400 milligrams, which was titrated to 800 milligrams at 2 weeks. And I did see there was a question in the chat earlier about why the dose difference. So as you know, with IgA nephropathy, it's a 400 milligram dose. With FSGS, it's an 800 milligram dose. So sparsentan is largely protein bound. And so because these patients with FSGS do tend to spill more protein, the higher dose, that was sort of like the rationale. The other part of that is that in our phase 2 DUET study, when we were using the dose finding study for sparsentan, we looked at doses of 200, 400, and 800. We found that the 800 milligram dose was more likely to achieve complete remission of proteinuria than the 400 milligram dose. The percentages there were about 52% of the patients on 800 milligrams got to complete remission, whereas when we looked at the 400 milligram dose, about 43%. So we saw improved efficacy with achieving your proteinuria goals without any new safety signals. And so that's why the 800 milligram dose was chosen here for FSGS, where it's 400 milligrams in IgA nephropathy. I'll call out there at the bottom that the vast majority of patients in the study did tolerate the maximal doses. So about 91% of the patients did achieve that maximum dose of 800 milligrams of sparsentan, and about 90% achieved that maximum dose of irbesartan, 300 milligrams. So the data that we're going to show are really comparing max to max in each of these. So basically sparsentan at its max dose versus RAS inhibition on its best day. We'll look at some other key endpoints that I'll highlight as we go through. Very briefly, did want to show you some baseline characteristics. And so you see the average age in the groups were comparable, about 41 to 42 years of age. There was a slight male predominance. Note that these were prevalent patients and not incident patients. So the median time from FSGS diagnosis to informed consent was about 2 years. And so there was a question of, do we truly have primary patients in our study. As we do, they were just prevalent primary patients, not incident primary. Obviously, with an incident primary patient with FSGS, you need to think about immunosuppressive therapy, but sparsentan could certainly be, and adjacent to it. If you're planning on using RAS in that patient, we're going to show you data here that sparsentan was superior to RAS. So certainly you would do both at the same time. You would not use sparsentan as a replacement for immunosuppressive therapy in a newly diagnosed primary patient. We also see some other data here. So the starting proteinuria was about 3 grams in both groups. About 83% of patients in the sparsentan group were on RAS prior to enrolling, about 76, 77% in the irbesartan group. We see that around half used immunosuppression at baseline, and around 2/3, slightly above that, used diuretics. And moderate or severe edema occurred in about 9% of the sparsentan, or 9 of the sparsentan patients, and 6 of the irbesartan patients. Here's the initial data, and this is the proteinuria reduction. And so we're looking at these graphs. The purple bar is irbesartan, the teal bar is sparsentan. And so just like we saw with IgA nephropathy, with sparsentan, you see a rapid and sustained reduction in proteinuria that was superior to irbesartan. And those graphs differentiate quite early. So right around week 6, we're already seeing pretty significant differences. And that persists throughout the 108 weeks that the patients were studied. So there's about a 50% reduction in the UPCR from baseline on the patients on sparsentan, compared to a 32% reduction in the patients receiving max label irbesartan. And those data were significant. Now, when we look at a little bit more data here, when we think about proteinuria cutoffs and proteinuria goals, we're showing 3 here. But in each case, sparsentan outperforms max label irbesartan. And what we notice is the more stringent you are with your goals. So if you're moving from, well, I want to get to less than 1.5 grams per gram, I actually want to be more aggressive and follow what Parasol recommends at 0.7, or I'm now targeting complete remission, even based on what I've learned from RADAR. We see that sparsentan outperforms irbesartan each time, and that relative risk, or in other words, that relative likelihood of achieving that goal, increases the more stringent you are. So about 18.5% of our patients in the sparsentan group got to complete remission, compared to 7.5% of the patients in the irbesartan group. Now, we obviously want to show our eGFR data. There was a numerical difference in the eGFR slope, and the mean change from baseline did favor sparsentan, but these results were not statistically significant. Dr. Trachtman did speak to that a little bit when we showed the Parasol data of the difficulty of designing a trial that did show statistically meaningful eGFR slope. Now, we do have data in our package insert that shows that in the patients without nephrotic syndrome, there was a statistically different significant slope in the patients in the sparsentan group versus the irbesartan group. That was an additional cut that was requested by the FDA, and we'll have more information this fall looking at the characteristics of those patients. So these data will be presented at ASN and some other fall conferences, looking at the groups, dividing them out between nephrotic and non-nephrotic syndrome. The last piece I want to show here is kidney failure. And we do show that fewer patients reached kidney failure with sparsentan than in the irbesartan group. And again, these numbers are not statistically significant, but there is a trend. So during the 2-year study that the patients were followed, 6.5% of the patients receiving sparsentan in the DUPLEX trial progressed to end-stage kidney disease. Compare that to 11.2% of the patients in the DUPLEX trial who received irbesartan. Now, we then looked at a RADAR DUPLEX aligned study. So basically, we took the patients that were in RADAR and tried to pick characteristics and pick patients that most closely matched who we studied. And you see there that their risk of kidney failure over 2 years was about 11%. So very similar to our comparator group. And then finally, that last graph there is the FSGS CT study. So this was a multi-center prospective open label study looking at mycophenolate in conjunction with pulse steroids, comparing it to cyclosporin in FSGS patients, and it's just showing the incidence of kidney disease, kidney failure there, and it's 13.6%. So just as a kind of a randomized trial, which is another way to kind of compare this. So I want to bring in Dr. Trachtman and Dr. Appel, and Howard, I think I'll start with you. So DUPLEX showed rapid and sustained proteinuria reduction through the 108 weeks. For a glomerular specialist audience like we have here today, what's the most clinically meaningful aspect of the DUPLEX data that I've gone over?
that people shouldn't lose sight of the importance of reducing the proteinuria, and the fact that the change in GFR was trending in the right direction but wasn't statistically significant should not be looked upon as a fatal flaw of sparsentan, but rather a reflection of the biological variability of FSGS as a targetable disease entity. And this is really visible in, we should have known this. It was in plain sight. If you look at the data comparing the eGFR slope data between PROTECT and DUPLEX, it's clear that the variability in eGFR was much smaller with IgA nephropathy. There's a paper by Tom Green and Leslie Inker from, I think it's Nature Medicine from 2000, I think it's 25, and they clearly show that the variability in glomerular disease GFR slope is in the aggregate, which includes FSGS, IgA, and everything, is much more varied than it is for diabetic nephropathy. So we really should have been prepared to recognize that eGFR, while it remains the gold standard of what's meaningful to clinicians and to patients, proving that in a 2-year period of time was really, really beyond feasibility in a trial that patients will sign up for. But the reduction in proteinuria is clearly associated with that long-term effect, and therefore people shouldn't make an automatic. They shouldn't walk away from this meeting, I hope, and think that we think the proteinuria and eGFR are different. They're integrally linked. They're both reflective of glomerular function. However, in the context of clinical trials for FSGS, it's more practical to base a study on a proteinuria endpoint with the understanding that that's going to be associated with a meaningful and demonstrable and verifiable preservation in GFR in the long term. And one thing I just want to emphasize that what the approval for FSGS based on proteinuria is not an accelerated approval. It's not that it's a reasonably likely surrogate, but it's a validated surrogate that the change in proteinuria 2 years is predictive of a meaningful change in GFR.
No, I appreciate that, Howard. Now, Jerry, I want to also bring you in from the clinician side. So when you look at DUPLEX, what helps you translate these data into a real patient that's sitting in front of you?
Yeah, so it's all of the things we've been talking about. It's the proteinuria reduction, it's the durability over the 2 years of the study, the complete remission data. But one of the things that I think is very important, because of the somewhat controversy that was going on about slope of the GFR, versus chronic slope and total slope, that the fact that there was less kidney failure, I mean, it looked like a 50% reduction in kidney failure. And now that is just a major thing. I mean, it supports the thought that, yes, over time, this proteinuria is going to lead to more and more patients staying in remission. And again, you can argue about is it statistically significant or not, but that's a huge difference there. It's a 50% reduction here. The other two things I would mention is that this is one of the few things, we've been using it for IgA nephropathy since 2003 when it got approval, but almost all the other drugs that were used were versus placebo. This was a drug that had a real comparator in terms of irbesartan. This was comparing it to the state of the art at that time. And the other thing that impresses me about these studies that I know you're going to come to is safety. The FDA approves something for kids, I always know it's much safer than other drugs. That this is certain drugs, for instance, for lupus, they've got FDA approval for over the age of 5 or over the age of 8. You know that the data is very good if the FDA is going to do that, and this is approved for kids as well. So it's impressive data, I think.
Thanks, Jerry. And that brought up this year. So I was going to go through some of the safety information. Here we compare sparsentan to irbesartan, and we can see that the safety profiles are very similar to them. Now, recall that DUPLEX was done at the height of COVID, so obviously it's not surprising that COVID is one of the AEs reported. But when we look at the other side effects, hypotension maybe occurs with slightly more frequency in the sparsentan group, but the incidence of CKD and other side effects that we see here are all very similar. There was a question in the chat, and the question was, did you see more incidence of hypotension, hyperkalemia, and other side effects when going to 400 to 800? Really, we did not. So in DUET, the side effect profile looks very similar regardless of the dose. And so that's, again, the reason for the recommendation for the 800 milligram dose is that you're getting more efficacy without any trade-off in safety. And now, Howard, I know, obviously we did a pediatric paper with Dr. Michelle Rowe that was recently published in KI Reports. We're not showing all the pediatric data here, as I know this is predominantly an adult audience, but can you comment on, just briefly at a high level, what they saw in that pediatric specific population?
Thankfully, what we've learned is that if you have FSGS, it's just as bad if you're 10 or whether you're 50. And with the pediatric subset analysis, and it was a substantial number of patients, about 35, that the efficacy in reduction in proteinuria was exactly the same in the pediatric and the adult patients. So whether I'm an optimist, I'm not sure, but the disease is horrible no matter what your age is. Sparsentan is an effective drug regardless of what your age is, and therefore the implication for me would be that the long-term impact of the reduction in proteinuria and preservation in GFR should be equally applicable whether you're 10 or whether you're 50. And I think that's very, very encouraging in terms of improving and enhancing the number of options available to pediatric nephrologists dealing with patients with FSGS.
Thanks, Howard. And that was a paper by Michelle Rowe and in KI Reports published just this summer, if there are any pediatric nephrologists on the call interested. Now, I do want to just kind of quickly summarize here. So DUPLEX, again, one of the largest interventional studies in FSGS to date, comparing sparsentan to active irbesartan maximum label. We showed a greater and a more rapid reduction in proteinuria. More patients achieved those lower proteinuria threshold targets. Fewer progressed to end-stage kidney disease, and again, had that well-tolerated safety profile. Now, I want to zoom in a little bit on our genetic patients. And so these are data in our patients with genetic or genetic-associated FSGS. And these are data from a C. Jason manuscript that was just published. Dr. Yee is the lead author, but obviously Dr. Trachtman also very involved with this paper as well. And so kind of a quick overview. We know that in genetic FSGS, there's really a need for effective and tolerable treatments for these patients. We know they're often refractory to corticosteroids and other forms of immunosuppressive therapy, and despite that, still have a very high risk of progression to end-stage kidney disease. So this was a post hoc exploratory analysis of our DUPLEX data. So recall, DUPLEX had 371 patients enrolled, and of those, 355 did have genetic sequencing performed. And of those, we identified 70 patients with genetic or genetic-associated FSGS. And we see the breakdowns here. So the podocyte gene variants, we had 31 patients. The collagen variants, we had 25. And ApoL1, a little bit less represented, but still had 14 patients there in that cohort. Oh, the podocyte gene variants were very well represented, predominantly the MPHS2 variants, but we had others, as well, that were looked at here. And what we show is that the percent change in proteinuria from baseline in these patients with podocyte gene variants through week 108, these graphs look very similar to what we showed in the DUPLEX overall population. So sparsentan has that rapid and sustained reduction in proteinuria that was numerically superior to what we saw with the irbesartan group. We also see on the right-hand bar there, the bar graphs, one of the 13 patients with the podocyte mutations did achieve complete remission. And then when we look at the bottom bar graph there, as far as the patients achieving the composite outcome of kidney failure or an increase in eGFR, we see that favored the sparsentan group as well. 1 out of 13 in the sparsentan group achieved the composite failure endpoints versus 4 out of 18 or 22% in the irbesartan group. Now, the next we're going to look at here is the collagen 4A 3 through 5 variants. And this comes up frequently because many of our nephrologists are also thinking about Alport syndrome. So while Alport syndrome by itself, if you just have an Alport's patient, they would not necessarily be a candidate for sparsentan. If the patient has Alport syndrome and biopsy findings consistent with FSGS, they would be an on-label appropriate patient for sparsentan. And so we're going to look at these different collagen groups here as well. What we show is, again, very similar to what we're seeing throughout the course. So regardless of the patient populations we're looking at, we still see that sustained decline in GFR. And this group, at 6 weeks, had about a 60% reduction in proteinuria that finishes out at about 40% in the sparsentan group. And again, these patients on sparsentan are more likely to achieve complete remission, 18% versus 7% in max label irbesartan, and they're less likely to achieve those composite kidney failure outcomes. So again, showing benefit here in different forms of genetic or genetic associated FSGS. The last group, and admittedly this is a smaller group, it's looking at the APOL1 high-risk genotypes. And you see that same reduction, but again, the ends get very small here. So by the end, the irbesartan group only had 3 patients, the sparsentan group had 6 patients. So you see the reductions in proteinuria on the line graph. You see that more people did achieve complete remission in the sparsentan group, and they were less likely to reach those composite kidney failure outcomes. But again, we know that the ends here we recognize are small, and this is certainly an area that Travere is interested in continuing to look at, because this obviously represents an underserved and disproportionately affected patient population that obviously is in great needs of therapy. So Dr. Trachtman, I want to kind of come back to you here on this, as we kind of summarize, but as someone who really led these analyses and led the charge here with looking at genetic FSGS in the DUPLEX population, what are some important clinical messages, important clinical takeaways?
I think what I get out of this is that I think historically genetic forms of FSGS were considered to have the worst prognosis, and they were often viewed as refractory to therapy, and their prognosis was viewed as the most guarded. And the fact that this drug was able to reduce proteinuria and it's similar to the overall group, because it's a substantial number, it's 20% of the total enrollment, is really reassuring. It should be noted that the patients in the APOL1 group were older and they tended to have a higher BMI. So it's conceivable that metabolically they were a somewhat different disease, and that may affect this somewhat less robust effect of the sparsentan. But overall, if I were a clinician, I would say that having a genetic documentation as the cause of FSGS should not represent any hindrance to the use of sparsentan. And correct me if I'm wrong, Jerry, my understanding is that as more adult nephrologists are incorporating genetic testing, a substantial number of adult patients are being identified with genetic causes, and therefore this application should not be confined exclusively to pediatrics, but across the board.
I absolutely agree with Howard on this. That it used to be, I always used to say, we have 7 full-time nephrologists at the Glomerular Center at Columbia, so it's about 3,000 patients with non-diabetic glomerular disease that we see. I used to say you couldn't get into the office without giving us a cup of urine to dipstick to check for proteinuria. That in fact, I used to tell the drug reps they couldn't come in unless they gave us a cup to dipstick. But nevertheless, now you come in and the first thing we ask about is, can we get a cheek swab for genetics? So I think it's absolutely correct. In a study we did that was at Columbia it was published in the New England Journal a few years back, but it was mostly from the Glomerular Center. 10% of the patients had a genetic defect, and most of them were not known. One of the most common genetic defects was the collagen 4 defects. And most of those people were misdiagnosed as focal sclerosis, idiopathic focal sclerosis. So genetics is very important. In fact, I think the 2 biggest changes I've seen in glomerular disease that makes it so exciting are 1, genetics, and 2, the newer drugs. We can treat all these things that we couldn't treat before. And that's why Howard and I are still here. And Dick's still here too.
And Jerry, what are you doing different now in those patients that you're identifying? So obviously you're being more aggressive about screening for them, which I think is really important, but how has your management changed over time with those genetic patients once you identify them?
So the biggest thing is not treating it as an immunologic disease that needs to be treated with immunosuppression. That many of these people come to us having failed 6 immunosuppressive drugs, and they say, what else do you have to offer? Well, we have to offer that it's a disease that should be treated in a totally different fashion. So the therapy aimed at preventing glomerular damage is very important in these people. Now, I know, of course, the studies are ongoing now in terms of trying to change the podocytes itself for TRPC6 and APOL1, but right now we have a lot that can slow the progression of disease in these people without exposing them to immunosuppressants. That's without even mentioning what, if they go to transplant, what it means for which kidney they can get and what they should think about for their kids with genetic disease. So in adults, even though, I know this is so important in pediatrics, in adults, it's terribly important in terms of a glomerular center. I mean, a lot of people have these diseases.
I want to give some key takeaways and then get to some of the other questions in the chat that we've not yet answered. So a couple of key takeaways here. First and foremost, so Sparsentan now approved for FSGS in both our adults and our pediatric populations to reduce proteinuria in patients without nephrotic syndrome. And it does so by targeting both endothelin and angiotensin, which are both key mediators of podocyte damage that contribute to proteinuria and ultimately progression to kidney failure. We've shown in RADAR and Parasol that lowering proteinuria is associated with lower kidney risk. And then we spent some time looking at the DUPLEX data showing Sparsentan's superior proteinuria reduction against max label irbesartan with a well-tolerated and a similar safety profile to irbesartan. And then we spent some time on the genetic subgroups and also, Howard talked about the pediatric patient population that showed basically comparable effects with that proteinuria reduction with similar safety profile. So I spend some time jumping into the chat here to kind of get some questions. I know Dr. Glassick had one that I wanted to read out here probably for Howard, but Jerry chimed in as well. Parasol and RADAR led to a shift away from percentage reduction of proteinuria towards basically remission as an endpoint. Very different from IgAN. Any comments?
It's a great question. And what my sense is that because the proposal to use proteinuria as a validated surrogate for full approval of a drug, the cutoff of 0.7 was selected to potentially assert that this was a meaningful change, that the reduction in proteinuria was not trivial, and it was biologically meaningful, and that it was linked to the hard outcome of reduction in GFR. And what I would say is I think that the approval of Sparsentan based on proteinuria, the FDA, I think, is much more open to other assessments of changes in proteinuria, percent reduction, different cutoffs, and a lot of trial outcomes are looking at just the way you described, Chris, the different cutoffs, 0.3, 0.5, 0.7, 1, and 1.5. So I think that we haven't written the final chapter on what criteria for proteinuria will represent the endpoint, the validated surrogate for full approval of a drug. But I think what the DUPLEX trial has done is it's really changed the focus, and it's enabled proteinuria to be considered a meaningful biologically relevant variable to be assessed for approval of drugs. I think it's an open question, and I don't think people should look at the 0.7 number as the end all and be all and the final word on this in this conversation.
And Howard, Dr. Glassick also had a good question about the underrepresentation of primary FSGS in these cohorts. So he said, since the registry cohorts were underrepresented in primary FSGS, can we be sure that the conclusions of Parasol coming from the lack of the EGFR or values of the EGFR slope can be uniformly applied to primary patients with nephrotic syndrome?
Jerry, you want to go first?
Yeah, well, the drug is approved not for primary FSGS. It's approved for, it's in nephrotics. You can't have nephrotic syndrome at the time. So now it's a little tricky because Chris pointed out that there are 3 criteria. You have to meet all 3. So you could have been a primary person who you got rid of the edema by treating with diuretics, or you got the proteinuria down using something else, and you got it down from 5 down to 2 point something. So the criteria for nephrotic syndrome are variable here, but again, the data has been shown in nephrotics and non-nephrotics here in the DUPLEX trial, and that's very important. You have both groups there that, and to me, of course, it's not just the proteinuria, because I think that question about percentage and absolute values is very important, but it's the fact that there's less kidney failure in these patients. It's already showing up in a 2-year study, that it's twice the difference here. So hopefully further follow of these people, the extension studies will show that this goes on and actually the curves get bigger and bigger over time.
And the only thing I would add to that is I think as a nephrology community, as One of the wonderful things about the DUPLEX trial is it has made clinical trial activity in the context of FSGS feasible, and we move forward with novel agents that are being developed for the treatment of this disease. We as a community, I think, need to work harder to define what primary FSGS means with these different categories. The KDIGO guidelines, which breaks it into the 4 subgroups, is now the current standard, but I think we're learning that FSGS is biologically very variable, and I anticipate that our classification scheme is likely to change and grow and become more meaningful over the next couple of years as trial activity becomes more promising and more of an opportunity for industry and drug developers.
Yeah, I also feel that for Parasol has the advantage that it's not a pharmaceutical sponsored group. These are all NIH, well, not all NIH, some of them are European, but Neptune and CureGN are NIH sponsored studies. So there's that bias is taken out of this when they say they get the same results as Radar, et cetera, which is the health service in the UK sponsored. I mean, you're getting pretty good data out of it.
Yeah, and we're looking forward to seeing the Parasol publication soon. So stay tuned for that. Now, one great question that came in at the very beginning that I definitely wanted to get to is sequencing. So it seems like this is going to be an issue, just like we had with IgAN, as the years go on. But this question specifically was, if you give a patient steroid treatment or CNIs for FSGS, would you give sparsentan simultaneously? Would you wait to see their response for a steroid course, which could be up to 6 months in duration? But I guess, I'll start with you, Jerry. Is like, how are you thinking about these patients now when you're treating them in the clinic?
Again, I look back to, the current classification, which again may be modified over time. But if somebody, has a primary cause with complete foot process effacement and came in with 10 grams of proteinuria, even if it's been reduced down to you got rid of their edema, and they now would be a candidate for a drug like sparsentan. I still consider that an immunologic disease, and that's what we should be focusing on. And especially since we're getting new therapies. On the other hand, for the entire rest of the group, the secondary forms, the genetic forms, and those who have subnephrotic proteinuria, those are the people that I would concentrate and say, look, they're all candidates at this point. And I am using it, now in genetic diseases, whenever we can get it, whenever, they say that the criteria are fit, they did want a certain amount of proteinuria, but I think this is, going to be a long-term issue. It's like ACE inhibitors and ARBs. You need a control group. I know for the Alport's groups have always used, former SIBs that had the disease and progressed and their course versus the ACE inhibitor ARBs, and I think that's what's going to have to be the case in terms of things like sparsentan.
There were also some questions on some rebiopsying studies and looking at some specific biopsy findings. I can tell you, as of right now, we do not have rebiopsy data on any of these patients from DUPLEX. But very similar to the way we designed the Spartan study in IgA nephropathy, and we'll have more data to share on that at ASN this fall. That's certainly something we could explore, right? Is looking into that, especially if there was an interest with others in looking at rebiopsy data. So certainly always an area of interest, and also they're kind of looking at specific biology, morphologic findings. We don't really have any of that data to show necessarily who's responding, better than others. We don't have any data there. There was one other question there on the effect of post-transplant FSGS patients. And so we do actually have an ongoing study here in the United States called SPARX, SPARX, and that is looking at patients with post-transplant, either recurrence of IgA nephropathy or FSGS. So those trials were enrolling. We did present just sort of a trial in progress, poster at ATC, and we will have more data to share on that, going forward. I know we're coming close to time, so I guess, to both of you, to Jerry and to Howard, I guess if we could leave the GlomCon group, these glomerular specialists, with kind of one or two big takeaways to think about here with regards to management of FSGS, what would they be? And I guess I'll start with you, Howard, first.
I think one thing I would want to highlight is what an enormous accomplishment this was. That this, I think I could go. I think I'm accurate when I say this is the largest randomized control trial that had ever been done for FSGS. It was done at a very difficult time in our public health life as a country during the COVID outbreak. So the fact that 371 patients, including pediatric, including genetic subsets, it's a meaningful accomplishment that it spurred really creative and meaningful conversation about what would be suitable endpoints, and that the Parasol initiative, which really was a direct outgrowth of the fact that we could document a proteinuria endpoint, but not a GFR, grew out of FSGS. So I think it's really altered the whole people's mood about what we as a community of nephrologists working with the community, working with patient advocates, what we can do as a group. And I think it's really restored hope to the future that we can develop safe and effective therapies that will improve outcomes in patients of all ages with FSGS. And I think it's an enormous accomplishment, and hope that's appreciated by the community at large.
And Jerry, kind of one final thought for you before we wrap up?
Well, I certainly agree with that, this is our first drug approved for focal sclerosis, and I'm hoping that there'll be many more that come out in the near future, even for genetic forms, etc. But I think looking at this is a large controlled trial which had the comparator that we're all using. We're all using ACE inhibitor ARBs. The internists put the patients on it when they come to us, even before they come to us. So here we have a drug that is superior to that. And here you're now seeing kidney failure data, which makes a big difference too. It's confirming that the proteinuria makes a big difference. And you have the safety data. We've been using it for IgA since 2023, and actually before if you did any of the studies. So we've been using it for a long time already. It's approved for use in kids as well, which again is reassuring to me. And you can tell that to the patient. This is a drug that the FDA even says you can use in children. With good efficacy over time, I think it's very persuasive data. So.
Well, Howard, Jerry, thanks so much for a great discussion today and for adding in. I think your pearls really added to the clinical data that we presented. And to GlomCon, obviously, and from Travere, thank you so much for giving us this opportunity to walk through data and interact with you and kind of go through this, as we hope to help you all improve your management of FSGS. So with that, I'll turn it back to Dia. And again, thank you all.
Thank you. Thank you. It's wonderful to hear new medications out there in our armamentarium, and to have experts on here have a wonderful discussion. So thank you all. Thank you, Chris, and hope to see many of you very soon.
Thanks so much. My pleasure. Take care. Have a great Sunday.
Thank you.
Bye now.